on flare and T2 and hypo-intensity on T1. Here you see the skull deformation. If you see another case with here many cysts, it is very characteristic of the DNET. No edema. A very important thing in the DNET that is very frequent in children, it is the absence of enhancement. In children, it is not the same in adults. So you have sometimes hippocampal involvement. So the important differential diagnosis is the gangliogliomas. It is a benign tumor, a WHO grade 1, and we have the same clinical presentation, the same seizures, but we have in ganglioglioma a nodular enhancement, you see here. And we can have in gangliogliomas a cyst. Here, the CT scan with calcification and hypointensity on T1, an enhancement, hyperintensity on T2 and flare. Here you have another ganglioglioma with a very big cyst. So another differential diagnosis is the low-grade oligodendrogliomas, but it is very rare and difficult in children. You have a blurring, and you could say that it is a dysplasia. So now we have seen the dysplasia, the ganglioglioma, the DNET, and now we have a girl, 8 years old, and she has epilepsy, retractable epilepsy, and we have an hyperintensity here in the temporal right pole, and here as a blurring, and here, and what you say, what is it? Yes. Thank you. You have to perform a contrast injection because it was a tumor, it was a ganglioglioma, but it is not the same thing to say it is a dysplasia and the child have remarked it is a dysplasia and he goes to the pediatrician and the neurologist and it is a dysplasia and they don't control the MRI, but it was a tumor and it is growing. So it is an oncology problem and not an epileptic problem. So take home message, you have to perform an injection if the MRI is abnormal. So for the reports, you have to study the cortical duration and be careful, gyros by gyros and sulcos by sulcos. You have to study the myelination according to the age. It is not the same thing. If he has 2 years old, it is very difficult. You have to repeat the MRI. You have to see always the anatomical analysis of hippocampi and temporal poles. The dysplasia are very frequent in the temporal poles, and you have to count the 5 branches. And don't hesitate to perform a second MRI after the end of the myelination. Very important. So we have answered the question when to perform non-idiopathic epilepsy. Why? For the treatment, especially for the surgical treatment. Which type? It is always the MRI, but it is a tailored MRI. Which sequence is always a 3D-T1, flare, T2, and T2 star, perhaps, if it is normal, and an injection if it is abnormal. Always the myelination and age, and we have limits if we are in the 3 months till 3 years of the child. So we have a brain imaging in progress now. We have a technical revolution, and for example here, 35 years of pharmacoresistant epilepsy in a man, and he has CT and 2 normals MRI, and finally at the 3rd MRI we have seen with the flare and hyperintensity, and he has a dysplasia and he has surgery, and after it was a correct life. He has a correct life. Now with the technical technology we have a 3D flare, and it is important for the surgeon to limit the dysplasia, for example, and I hope we are going to have the 3 Tesla, and it is very easy, or more easy, to see the cortical dysplasia. You see here than here. And we have now a magnifique, formidable sequence. It is arterial spin labeling, perfusion without injection. And for example, here it is a girl with epilepsia paralysis continuing in the left arm, always, and in the machine, without injection, in 5 minutes, we have an increase here of the cerebral blood flow. Here, for example, a focal cortical dysplasia. You see here, perhaps, yes, the focal cortical dysplasia, as I saw. Here, the cortical dysplasia, but it is very, very difficult. The neurosurgeons don't want to go here. So, we have to perform the ASL, and here you see the focal hypoperfusion in ASL that matches exactly with the morphological MRI, and that matches exactly with the positron emission tomography hypometabolism that is the gold standard. So, it is very, I think, now we have the ASL, and we are very happy. And in the protocol of MRI, 3DT1, FLAIR T2, and perhaps gadolinium, we have to perform the ASL. So, just to finish, Jean, 5 years old, right motor epilepsy, and he has right motor epilepsy. What do you think? What do you perform? You don't see anything. You don't perform contrast injection. T2 star, Laurence. Yes, it was a cavernoma. It is very important. It is very important to have T2 star, take home message, T2 star. It is very important if it is a normal MRI in intractable epilepsy. Because in children, it is not calcified. 10 years old, a girl who has a parosmia. What do you see? We are going to see the temporal lobe, and you have to count the 5 branches, as I said. What do you see? Left, right? Left. Left. You have to count 1, 2, 3, 4, and 5. And here you count 1, 2, 3, and a blurring. A blurring on T2, a blurring on FLAIR, and a very important thing that in axial plane you don't see anything. So if you made a 3DT1 and an axial T2 and axial FLAIR, and you put it as a normal MRI, we are going to have an intractable epilepsy with 1, 2, 3 treatment, and perhaps it is very important to repeat the MRI and to perform the T2 and the FLAIR and to look very, very strictly the MRI. Thank you very much for your attention.